ABC Women would like to thank BIPOC Executive Search for sponsoring today's episode.
The BIPOC Executive Search app is here for you. Get information about job opportunities we're recruiting for. Keep up to date and in the know about career news tailored to Indigenous, Black, and other racialized audiences. Gain helpful tips and learnings to help you on your career trajectory, celebrate job appointments, and more. The BIPOC Executive Search app, here to elevate the candidate experience for Black, Indigenous, and communities of color. Free to download and available on iPhone and Android smartphones.
Look how far you have come on your own, but never alone. Through the rain and through the shine, here's your moment, it's your time. You stood tall and now you see, standing in your destiny. 100 woman, growing strong. 100 woman, where you belong. You stood tall and now you see, you have reached your destiny, woman.
100 ABC Women would like to take this opportunity to welcome our viewers and listening audience, families, friends, and our sponsors to our inspirational conversations, Fireside Chats with 100 ABC honorees. 100 Accomplished Black Canadian Women is a bold initiative created by the co-authors, the Honorable Dr. Jean Augustine, a former MP, Donna Jones-Simmons, a corporate diversity executive, and Dr. Denise O'Neill-Green, Vice President, Equity and Community Inclusion at Ryerson University. Our mission is to celebrate and archive the professional accomplishments of trailblazing Black women from all across Canada. The goal is to create an ever-expanding database available for current and future generations via print media, public and private libraries, as well as a website, which is www.100abcwomen.ca. We are pleased to bring you a series of fireside chats which include conversations around education, healthcare, entertainment, creative arts, legal, technology, entrepreneurship, diversity and equity, media, engineering, politics, sports, and so much more. These, we know, are topics that matter to us and to you. These educational and inspirational conversations will be made available to all current and future generations via our 100 ABC YouTube channel. This is a great way to learn from our elders, brilliant-minded and accomplished Black Canadian women. 100 ABC Women would like to take this opportunity to welcome our viewers and listening audience, families, friends, and our sponsors to our inspirational conversations, Fireside Chats with 100 ABC honorees. 100 Accomplished Black Canadian Women is a bold initiative created by the co-authors, the Honorable Dr. Jean Augustine, a former MP, Donna Jones-Simmons, a corporate diversity executive, and Dr. Denise O'Neill-Green, Vice President, Equity and Community Inclusion at Ryerson University. Our mission is to celebrate and archive the professional accomplishments of trailblazing Black women from all across Canada. The goal is to create an ever-expanding database available for current and future generations via print media, public and private libraries, as well as a website which is www.100abcwomen.ca. We are pleased to bring you a series of fireside chats which include conversations around education, healthcare, entertainment, creative arts, legal, technology, entrepreneurship, diversity and equity, media, engineering, politics, sports, and so much more. These we know are topics that matter to us and to you. These educational and inspirational conversations will be made available to all current and future generations via our 100ABC YouTube channel. This is a great way to learn from our elders, brilliant-minded and accomplished Black Canadian women.
Please join me as I welcome our moderator for this episode, Healthcare and Medicine, Jacqueline Dixon. She is a radio and TV host. Without further ado, Jacqueline Dixon.
Hello, and thank you for joining us for another fireside chat with the 100 accomplished Black Canadian women. Today's episode is about healthcare and medicine, and I have three distinguished guests with me, and I'm very happy to have them introduce themselves. I'm going to start with Dr. Linda Maxwell. Good afternoon, Dr. Linda. How are you today?
Good afternoon, Jacqueline. I'm very well, thank you.
Please tell us a little bit about your background and the specific field that you study in.
I'm happy to do so, and thanks so much for the invitation, and thank you to all the organizers of this great event. So I'm Linda Maxwell. I'm a double board certified ear, nose, and throat facial plastic surgeon. Over the many years that I've been in practice, I got an interest in business and pursued an MBA. Which then sparked an interest in innovation. And many years ago, it seems like, I founded the Biomedical Zone, which is a med tech and digital health startup incubator here in Toronto, where we cultivate and foster the growth of innovative technologies in the hospital environment.
Thank you so much. My next panelist is Dr. Josephine Etowa. Good afternoon, Dr. Josephine. How are you today?
Good afternoon, Jackie. I'm doing well, thank you. I'm Josephine Etowa, full professor in the School of Nursing, the University of Ottawa. I hold a research chair in Black women's health, HIV Prevention and Care. And I am also a fellow of the Academy of the American Academy of Nursing and West African College of Nursing. I currently I'm one of the founding members of the Canadians of African Descent Health Organization in Ottawa, where we've been mobilizing the local community to really look at the impact of the health inequities that exist in our communities in a number of disease conditions. Thank you.
Thank you so much for sharing that. And our next panelist is Dr. Juliet Daniel. And good afternoon, Dr. Daniel. How are you today?
I'm fine, thank you. Good afternoon, everyone, and thank you to the organizers for inviting me to participate in this incredible fireside chat. I am a full professor at McMaster University and a cancer biologist, and I am the Acting Associate Dean of Research and External Relations in the Faculty of Science. I'm also a co-founder of the Canadian Black Scientists Network, which we will hopefully can talk about a little bit more as our conversations progress this afternoon.
Thank you. So ladies, let's get right into the conversation today. It's a really deep and broad topic. I want to start with Dr. Linda Maxwell. Dr. Linda, having completed medical training, how did you choose to specialize in the financial aspects of innovation and technology? Could you briefly describe a few of the projects to assist the audience understand your role?
I'd be happy to, and thanks for the question. In a way, innovation and startup finance kind of found me. I was, born and raised in Canada, but spent a lot of time in the US for training for undergrad and medical school. But even in that time during residency, was never really exposed to innovation. However, when I went abroad for an MBA, after I'd been in full-time practice for several years. I did my MBA at University of Oxford, and in that environment, there's a large and robust innovation ecosystem. And that introduced me to the concept of early stage companies, disruptive technology, growing startups. So when I came back, there's an opportunity to form an innovation hub in the hospital, which is now Unity Health Toronto. And it has been a wonderful adventure in setting up a partnership with Toronto and Ryerson University to create a micro. So the Biomedical Zone is Canada's first and so far only hospital embedded med tech digital health incubator in Canada. And what we do specifically is we take early stage ventures and innovators who could be students, they could be doctors, they could be nurses, could be engineers, people who want to change healthcare for the better through innovation and multidisciplinary collaboration. So you have all different kinds of people all working together towards the same end, which is to improve healthcare delivery, quality of outcomes, efficiency, all of those good things. But you have them working together in the environment where the actual technology will be applied and used for patients and others. And so what you end up having is a very dynamic and collaborative environment. And just so people have an idea of what we do, for example, we will have, there have been many companies that have been engineering focused, so software and medical devices. They will come into our incubator after they're selected. We have a series of criteria to determine whether or not the fit is right for our incubator, because we lead with the need of the system. And we try to find technology that responds to needs within the system. And once they've passed the entry point, we will then cultivate their business strategy, as well as find, identify, and engage clinicians, key opinion leaders, system-wide decision makers to collaborate with the startup so that they can accelerate their development and get the technology to market. We've had over 50 companies that we've grown and incubated in the last 5 going on 6 years. Everything from wearable technology to monitor people's heart rate and cardiac rhythm remotely, to digital platforms for parents who are seeking health professionals for their children who have different abilities, all the way to ultrasensitive pressure monitors for robotic instruments to be used in surgery. So it really runs the gamut, but it's all with the idea of making healthcare better. So hopefully that gives you an idea of what we do.
That is absolutely mind-blowing and extremely fascinating to know the depths that you are involved in such a miraculous discoveries as for in the healthcare profession, and that you're playing an intricate role in that. Thank you so much for all that you do.
Thank you.
Dr. Juliet Daniel, cancer research, biologist, professor, McMaster University. Wow, it goes on and on and on, right? So tell us, why did you choose cancer research?
So I don't know if I chose cancer research or cancer research chose me. But unfortunately, during the last year of my undergrad degree, my neighbor in Barbados, where I grew up, died of breast cancer. And about a month after she died, my mom was diagnosed with ovarian cancer. And that same first semester of my 4th year of undergrad, one of my professors, Dr. Lita Raptis, came to class, literally jumping up and down and excited about the discovery of this class of genes called oncogenes. And these genes were found to be mutated in viruses. And when those viruses were infecting chickens and other model organisms, they were causing tumors. And so she was literally instilling in us this idea that the cure for cancer was on the horizon. This was the biggest discovery since, the discovery of DNA. And her enthusiasm was so palpable. I remember thinking, oh my goodness, I want to be part of this. And as I said, it all coincided, unfortunately, with the death of my neighbor in Barbados and my mom's diagnosis. And unfortunately, her succumbing to ovarian cancer 6 months later 5 days before my convocation from undergrad at Queen's University. So that cemented my fate, because I always knew I wanted to do research that would have global impact and that would impact society at large. And I wanted to do something that would give back to the Caribbean ultimately. And so I knew that in the Caribbean, we didn't have a lot of research at any, not molecular genetic research. We had obviously other types of research, but not that type of research. So that's how I went down this road of cancer research. And then after discovering and identifying the gene Kaizo that I named after my favorite calypso music, I spent the first 10 years of my career at McMaster characterizing Kaizo as a transcription factor. But I was still kind of concerned that I wasn't doing anything to help society per se in my research until I learned about triple negative breast cancer, or TNBC, that was disproportionately affecting and killing Black and Hispanic women. And that's when, so about 10 years ago was when we started that avenue of research in my lab to really try to understand what is underlying this predisposition and high incidence of triple negative breast cancer in Black and Hispanic women. And we're doing lots of molecular cell biology and genomics research to really get to the root of that. And we're also raising a lot of awareness in the GTA and in the Caribbean with various communities to spread the word about this, about just cancer in general, because many of us are aware that in our Caribbean and African communities, we don't like to talk about disease, and definitely not about cancer. Folks will talk no problem about diabetes or, heart and stroke, but they will not talk about cancer. So I partner with the Olive Branch of Hope Cancer Support Group in Toronto, and we run breast cancer and cancer awareness workshops for Black people in the GTA and in the Hamilton and Brampton regions. And basically trying to increase that awareness so that we get the treatment, we do the screening that's necessary so that we can save more lives and maintain a strong Black community.
Awesome. Thank you so much for that. And I had no idea that it was such a personal journey that you took in order to get to where you are today. Congratulations to you for that. Dr. Etowa, wow. It's so awesome having you here. Your specialty, your field of medicine is quite interesting to me for the reason that you specifically delve into the medical issues of the Black communities, particularly Black women. And so my question to you is, I have a number of questions for you, but my personal question to you is, why did you feel a need to study Black women?
Thank you, Jacqueline. My motivation to study Black women actually began as a personal journey as well. When I migrated to Canada as a Black woman born and raised in Nigeria, I arrived here as a nurse. And I remember my first assignment as a personal care worker, not even as a nurse. While I was getting ready for my license exam, I walked into this home, and this person just saw me at the door and said, "You are not wanted here, leave." And I said, "Why? I'm a great nurse. I'm here to take care of you." "No, you don't understand English." I said, "Yes, I understand English." "No, you don't." And she came in a wheelchair to push me out of the way. I ran out in tears. That was my first job in Canada. I ran out of the room. This person lived in a condominium complex, so I ran to the commissioner and said, they said I cannot do my work. And so I had to call the home care agency that had sent me there, and she insisted she must leave. She's not allowed in my house. So and the next visit I went to similarly told me, "Give me your number. Give me the office number to call them so you can leave." And I said, "Oh, I'm a nurse. I can take care of you." And the second one, the agency told them, told this woman, "She's a great nurse. In fact, she's a qualified nurse, not just a personal care worker." And so this person allowed me to take care of her because she was convinced that I'm a registered nurse working for $5 an hour then. And at that point, I knew that I needed to do something. I could not do anything at that time because I was not even a registered nurse. But years later, when I went on to practice as a registered nurse. And I went back to school. That was my motivation to go back to school and learn more. Then I realized every time I wanted to do papers on Black Canadians, there was no literature, nothing. I would use American literature to justify the reason this is a problem and try to link it to the Canadian literature. And I went to my professor one day and said, every time I want to write papers about Black people, I cannot find anything about Black Canadians. And she said, you know what, Josephine, you can be part of the solution. And that was the beginning of my job. I wanted to examine the childbirth experiences of women, but I changed it to the experiences of Black Canadian women and use participatory action research. And I have engaged in that work ever since for more than 2 decades now, which has led to the creation of a number of organizations, but also written books and papers to really build that literature in Canada. And I do social science research for that reason, because social justice and equity is the cornerstone, I believe, to a healthy society. And to truly understand the health needs of Black Canadians, we really need to use a social justice lens, critical race theory, to examine the multiple levels in which the social locations we find ourselves in, whether it's gender as women or race as Black Canadians, how those intersect to impact on the health, the inequities we face. And I want to just build on a point that Dr. Daniel mentioned. She talked about Black Canadians or Black people not wanting to talk about cancer. They don't want to talk about HIV either. I do research in HIV and nobody wants to talk about that. In Ontario, we make up 5% of the population, but we make up more than a quarter of those new diagnoses of HIV. We have the same numbers in the country. We make up more than 25% of new diagnoses of HIV. And that is even in the context that most provinces are not reporting that race-based data. And so you can imagine if every province should tell us, give us that race, disaggregated data on race, you would see that even that numbers will be different. But Black people do not want to talk about it and even go for testing. And so it's really an issue. So I'll stop there. Thank you.
Thank you so much. That's amazing, amazing statistical information that you've just shared with us. And I thank you so much for that. You know, Dr. Maxwell, it's amazing when we talk to professionals like Dr. Etowa, how much we learn about personal experiences and how they shape our decisions in wanting to, you know, bring some benefit to our communities. And I'm sure that it wasn't much different for you as well. However, are there any specific projects of which you are particularly proud among the completed projects? Are there any that have directly benefited underserved populations, especially our Black, Indigenous, and other mitigated communities? Which advice do you have that you would like to share with us as well in regards to that?
Sure, thanks for the question. I think just to level set, it should be known that there is a problem with inclusion and diversity and equity in technology, in healthcare technology. There is poor representation of Black and Black Canadian founders in tech widely, and especially in health technology, which then has trickle-down effects into the kinds of technologies that are developed, the kinds of patients that are included in studies as people validate their technology, the kinds of input data that, you know, machine learning and artificial intelligence algorithms are built around. There's poor representation, and that this has been a historical problem. So by virtue of the fact of me being in the middle of technology, I like to think that that helps to start to change the way things look in technology, specifically healthcare technology. As a Black woman, surgeon, founder of this incubator, it is my express mission not only to improve healthcare through innovation, but to make healthcare innovation look like Canada, both in terms of the founders, the investors, and the patients that are impacted. Having said that, we have had, not as many as I'd like, but we have had companies come through that have specific mandates and visions to impact the health of marginalized people, whether they be Black, Brown, Indigenous. One that comes to mind in particular is actually founded by two family doctors, which is especially interesting to me because in general, physicians are quite busy. But their digital platform is really centered on education. And I think the panelists around the table will understand the unconscious bias that many clinicians have against Black and Indigenous people. You see them at the door in your office and you automatically think certain things, or you can't relate to their experience, which is a barrier to getting the kind of therapeutic alliance you need to get good outcomes. And so this particular company, founded by two family doctors who are very aware of this bias that clinicians and trainees often have, that they bring into the clinical practice at the, at the lack of benefit to Black and Indigenous people. What they did was they created a training program to help clinicians and residents and medical students put themselves into the shoes of the patient that's sitting across from them. And it cuts across a number of different factors like socioeconomic disadvantage. So you might be, it's a modeling exercise where you can put yourself in the shoes of a patient who, maybe is on unemployment or is experiencing homelessness. Or in other cases, there are scenarios where the clinician or trainee can put themselves in the shoes of a Black person who maybe lives in an urban center. That experience is very different than most clinicians, most doctors, even nurses may have. And you walk into a clinical exam room with your biases in mind, and it impacts the relationship. So that is a technology that is educational in focus, has definite health impact and social determinant of health impact. It's still a work in progress, but it's doing very well. There are a number of other technologies that may not be founded by Black or Indigenous people, but have those groups as specific beneficiaries. But this one in particular is interesting because it's so socially oriented, and it really cuts to the core of unconscious bias that clinicians carry with them into the operating room, the clinical exam room, when they look at patients, that we really must overcome if we're going to get health equity.
Thank you so much. Thank you so much for that. Dr. Daniel, listen, cancer research, that's a word that quite a few of us, most of us are familiar with, cancer. Yes, we don't want to talk about cancer. We don't want to talk about HIV, as Dr. Etowa has said, but cancer has been around. The sharing of information about cancer has been around for quite some time now. And there's been a lot of push towards finding a cure for cancer. Can you tell us, Dr. Daniel, in your opinion, have we made any advancements in that area? Do you feel that cancer research has made any advancements, and if so, in which area in particular?
So that's an excellent question. And I would say that, yes, we have made significant progress. I know that many of us in society may not think we've made progress, but we have made progress. There are, like, for example, I could say for childhood cancers and leukemias, there's been significant progress, and the survival rate now for many kids diagnosed with childhood leukemias, if they're diagnosed at early stages, the survival rate is over 80%, I believe. So that has been a significant advancement for childhood leukemias. Even for breast cancer, there are two therapies that are commonly used now that have also decreased the mortality rate significantly for women diagnosed with breast cancer, and that's tamoxifen and Herceptin. However, those only so tamoxifen targets estrogen receptor positive tumors, and Herceptin targets HER2 positive tumors. The breast cancer subtype that disproportionately affects Black and Hispanic women, however, those tumors do not express estrogen receptor or Herceptin. So there are no targeted drugs for triple negative breast cancer, and that contributes to the actual high mortality rate in triple negative breast cancer, which is then unfortunately affecting two populations that are already historically underrepresented in various professions in healthcare. And now there's basically a breast cancer subtype that there's no targeted treatment for. So we have made significant progress, but many of us that are doing cancer research also realize now there's this need for more genomic studies, because we're leaning towards what we call precision medicine or personalized medicine, recognizing that we're all unique. Even a set of twins will have slightly different genomic, I should say, signatures in their cells and their DNA. And so even though they may be twins and have the same diagnosis, whether it's HIV or even cancer, the differences in their genomic sequence will mean that they have to be treated slightly differently. And so there's now a recognition that this has to happen, which, as you can appreciate, is also going to be a very expensive venture. And this will unfortunately, or may unfortunately, if we don't adjust how we do things, lead again to more disproportional inequities towards certain populations and groups, because personalized and precision medicine, as you will appreciate, is likely going to cost even more money, because now we're going to be tailoring it to Dr. Maxwell, to Dr. Dan, and that is going to be a lot more expensive than just saying, hey, why don't all 4 of you women just take the same medication? So that, I think, is the challenge that many of us are aware of, and also why many of us are pushing for more equity type research, more race-based data collection, so that we really get that information to help us design and develop drugs better, and to do a better job as well at prognosis and diagnosis, so that we're really trying to see each patient as the individual and the beautiful human being that they are. So, but we have made progress. So don't think we haven't. It's just that we're appreciating the complexities. And even when I'm doing research and everyone thinks, well, why isn't there a magic bullet? We're like, because every time we make a discovery, we realize that, this gene or this protein, it does multiple things. It doesn't just do one thing. So if I target the one thing that I know it does, and then you have a side effect, then you'll be upset. And it's because we didn't know that it also did this other thing. So this is why we have to really, also promote what we call basic research, not just cancer research, basic molecular cell biology research, because we don't fully understand what all the thousands of genes and proteins in our bodies are doing. We know what, they're doing 50% of the time, but we don't fully know what they're doing. And to just design a drug knowing the little thing we do know is not a wise thing to do if we don't fully know or appreciate what that gene or protein does. So I'm really excited by Dr. Maxwell's work, and I'm looking forward to working with her at some point because I think that we can do so much more and capitalize on these technologies. So
I'm absolutely in 100% agreement with you. I mean, it's phenomenal when she's talking. I'm just like, really? Yeah. I've got so many questions for all of you, and I know we've got a limited amount of time, because the more you talk, the more I learn, the more questions I have. But I'm going to try to contain it within the time period that they've given us. Dr. Etowa, what are the strategies and structures necessary to advance equity, in your belief?
Thank you. To advance equity, there are multiple level factors that are implicated. These layers of factors that intersect or interact with each other to create those wicked problems, the social determinants of health. And so in order to address them, we must unpack all of those layers of factors. And so when we're talking about research to identify the issues that affect our health and create health inequities with certain populations that have been rendered vulnerable by some of the social distribution of resources or policies that impact on some group differently. We have to look at strategies and frameworks that help us to understand those multiple levels. And so intersectionality lens is one way that we can look at the health issues that impact on people of African descent here in Canada and most of the Western world as well. How can we study these factors in ways that we can understand the individual level factors We can understand the institutional level and community level factors, the values that drive decisions at our healthcare institutions, but also those systemic structures and policies that actually makes these things possible. So we have to bring values to account on that. So personally, as a researcher, I look at, in order for that to happen, we need people of African descent at all of these arenas, decision-making arenas. So in my work, I see any project that I do that it must have a component that builds capacity for ACB community people. And I use ACB because we're trying as hard as possible not to exclude anyone, A, for the Africans from the continent, and C, for the Africans from the Caribbean, and B, for the Black Africans who have been in Canada for multiple generations. And so the ACB communities in Canada need to be present. And so some of my projects are those ones that actually build capacity for upcoming researchers and students and healthcare professionals. And I think about a project I did in Nova Scotia that we called it On the Margin, Black Women on the Margin. And we examined the determinants of Black women's health across the province, especially in southwestern Nova Scotia, where we discovered so much. But the community facilitators that worked with us on that project actually were some of the key change agents that the training we did with that group, some finished and created organization in their community. Some actually went to run for offices, political offices. So they just took on a life of their own. Some used our findings to create plays, went to get funding to create quilts, traveling quilts. They travel around the province and plays that were showcased to show the determinants of Black women's health. And taking that further, we also used those findings to apply for funding for targeted recruitment for Black students into nursing. That program led to over 200% increase in our Black student enrollment at the Housing University where I was teaching at that time. And I'm hoping that we can do more of those kinds of strategy. When I moved to Ottawa about 10 years ago at the University of Ottawa, we also created a similar program for Indigenous students, targeted programming for the recruitment and retention of Indigenous students, and also that program to reserve some admission seats for qualified Indigenous students into nursing programs. Similar programs exist in medicine at the University of Ottawa. And so we need to build a critical mass of health professionals from these racialized communities that have been rendered vulnerable by the system. And so these people, okay, thank you
so much. Thank you so much. I know that there's so much to share, and it's such a powerful and moving topic. And as you were defining, I believe it's ACBN, is that the correct term for that network, ACBN?
ACB.
ACB. And I'm thinking community. ACB community, and I'm thinking how well represented the ACB community is in this particular fireside chat today. Isn't that awesome? So we represent that so well. So my last and final question really is for everybody, and maybe if you could just take just 2 minutes each of you just to share your personal take on the matter. We greatly appreciate it before we wrap up. The pandemic. Clearly, it's the elephant in the room. I mean, if you're talking healthcare, you've got to bring up the term pandemic at some point during the conversation. So my question to you is, how has the pandemic influenced health equity, specifically, dealing with your area of study? Maybe we'll start with you, Dr. Linda. Go ahead.
Sure, happy to, and it's a great question. They say there's you never want to waste a crisis. And I think if anything, this pandemic has blown the lid off of this problem of inequity, especially amongst Black and Indigenous people when it comes to healthcare. And in my specific field of innovation and technology, particularly when you start talking about data that gets fed into, software and algorithms that are the backbone of artificial intelligence and machine learning, the data just isn't there. And it hasn't been there for a very long time. People are not designing innovation, or hadn't been designing innovation for everyone. It was for the traditional groups of people who are well represented and who have the best predictors of, social determinants. And so, if anything, this pandemic has exposed for everyone, the pandemic and frankly, the crises south of the border and the social injustice south of the border, that constellation, the collision of those two has really brought to the forefront the issues of lack of representation in innovation at all levels, whether it's patient data, investors, founders, and it, I think, has started to generate some change around how we think about innovation, how we collect data so that we can be more responsive, not just with innovation, but when future pandemics come up, we're not caught without any mechanisms to, for example, collect data and then build vaccines or whatever it is that can help everyone in a somewhat personalized fashion. So it's a crisis and it's been terrible for so many people, but the silver lining is that now we're all talking the same language to a certain extent.
Thank you so much. Very well said. Dr. Daniel, same question to you.
Thank you. So just to follow up on what Dr. Maxwell said, and in the interest of time, I would say that this is definitely a significant disruption. And the silver lining as well is that this pandemic has shown us what we can do when there's a will to do it. Because for many of us at this fireside chat, we have been asking for years to collect data, or asking for years to have more Black and diverse students in the medical schools, or more diverse faculty or physicians. And there was always that we don't have the money, we don't want to tokenize people. And then suddenly it's like, oh, wow, we really don't have enough med students or nurses or Black professors. Let's do something about it. And we put out these advertisements and calls for faculty members, and then we get all these stellar students and stellar faculty members with, degrees from Oxford and Harvard and Cambridge, and people that are saying, well, if we have these targeted hires, well, we're going to lower the standards of the university. And I'm thinking, some of them are way better than us that are currently here. So, but we've known this all along, but many others have always thought that these would be affirmative action hires in any profession. And we know that that's not true. We know that we've worked twice as hard to be considered half as good, which means we're 4 times better. So that's just my basic math. So I think as disturbing and upsetting and emotionally exhausting as the pandemic has been, I feel like we're at this really critical juncture in society where we can make a significant change to really have all lives value, to really work together to create a better and much healthier world for every single human being. And I am hoping that we're part of that movement. And I just learned a term yesterday. Instead of trying to have consensus builders at our various committees, we need to be creating momentum builders, where we're getting all of the folks on our various committees to be part of that momentum to just propel us forward, rather than trying to have consensus and everyone agreeing. Let's agree, but let's create momentum to move forward at a faster rate than we've ever done before.
Fantastic. Thank you. Another very well put together statement. So Dr. Etowa, I'm going to leave it to you to finish up that one. Give us your take on how the pandemic has influenced health equity in the last segment of this show today.
Thank you. Building on the argument that my panelists, other members of the panel have put together, I actually also see this as a silver lining to the issues that affect ACB community members, in Canada. Because, like you've rightly said, we've been talking about this and not much has happened. And now we are talking the same language. We are able to come together at the table. And so I will finish my argument by encouraging ACB community members to come to the table, to get yourself to the table. If the doors are closed, go through the window, get in through the windows. If the windows are closed, let's create our own table and invite policy people. Let's see if they will not come to our table so that we can have this dialogue. We must, I think those coming in have to persevere. Perseverance is key because they may say those things to discourage us. We're not qualified enough. We may be intimidated by those who feel like they are more knowledgeable in terms of what the issues being discussed at the table. But we have to mobilize those who are prepared to mentor us, to be role models, to be able to learn and be at the table with the expertise we have and build on that so that we can be at the table to truly represent our own voices. We cannot wait for others to advocate for these changes for us. We have to be at the table. We have to be part of those generating the evidence, part of those people tailoring those evidence to address the issues. We have to design the intervention. So, like others, I'm so pleased to meet people like Dr. Linda Maxwell because I didn't know Black people were in these kinds of industries. So
we're here now.
Yes.
So excited. Thank you so much.
Yes. I want to finish with the slogan that nothing about us without us. We have to be at the table. Others can't do this for us. So thank you.
Thank you so much. Ladies, I'm in total awe right now. For this fireside chat, it's been fantastic. And once again, I just want to thank each and every single one of you for all that you do for our community, for being a part of the 100 ABC Black Canadian women community as well. And I've been hearing this word being used lately, but in a completely different context, and it's called disruptor. Growing up, we were told that disruptive people were not good, but now it's a totally different take. And I believe that you ladies are the disruptors that we've been looking for. Thank you so much for being with me today and have an absolutely fabulous day.
Thank you.
Thank you so much.
Thank you. Thank you for joining us on the 100 ABC Fireside Chat.
Look how far you have come on your own, but never alone. Through the rain and through the shine, here's your moment. It's your time.